Rectal bleeding. Case. Dear Doctor. Mr. Richard Venner, aged 56 years. Thank you for seeing this man who has noticed blood in his stools. Over the last 8 weeks he has also developed lower abdominal discomfort and feels that he has lost weight. On examination I thought there might be a mass in the right iliac fossa. He is understandably worried as his mother died of bowel cancer aged 70 years. I would be grateful for your assessment as to the cause of his bleeding and for further evaluation of his abdominal findings. Yours sincerely. Introduction. Rectal bleeding is a common problem and has a wide differential. The most common causes are hemorrhoids, colorectal cancer, and diverticular disease. Other causes are shown in Table 4. The patient's age is an important factor. Younger patients are more likely to have an inflammatory diagnosis, whereas those over 55 years have an increased risk of colorectal cancer. The suggestion of a right iliac fossa mass raises other diagnostic possibilities. Table 5. NB. The two main questions to ask about an abdominal mass are as follows. Is it related to the gut, including liver and pancreas, or another intra-abdominal organ, e.g. ovary, kidney? Is it part of a more generalized disease process? History of the presenting problem. Regarding the rectal bleeding. Duration, a long history, greater than 6 months, means that the diagnosis is unlikely to be carcinoma. When does it occur? Bleeding from hemorrhoids usually coincides with bowel opening, whereas bleeding from other causes may lead to passage of blood at other times. What is it like? Bright red blood is commonly seen in distal lesions, whereas dark red blood may be transported from the proximal colon. Is it malaena, which indicates an upper gastrointestinal tract source or occasionally a cecal lesion? Is it seen in the pan, mixed in with the stools or on wiping? Blood seen on wiping only is typical of a perianal cause, whereas blood mixed in with the stool suggests colonic disease. NB. Although hemorrhoids may occasionally bleed briskly, such symptoms should not be attributed to hemorrhoids without investigation. How much? Small amounts of bleeding may be caused by anal fissures. Large volumes of blood loss require investigation, but even benign causes may lead to substantial hemorrhage. NB. Patients often overestimate blood loss because small amounts can discolor the water in the toilet, giving the false impression of a large hemorrhage. Other symptoms. Perianal discomfort or itch may indicate hemorrhoids. Anal fissures may be exquisitely painful. Hemorrhoids are not usually painful unless they have thrombosed. Abdominal pain, that caused by diverticular disease, is typically felt in the left iliac fossa. Cramping pain may occur in colitis. Pain is generally a late sign in neoplasia. Severe pain accompanying bleeding in an ill patient is highly suggestive of mesenteric ischemia. Alteration in bowel habit, any change, particularly to diarrhea or looseness, is highly significant, especially in the presence of rectal bleeding. This would probably indicate colorectal cancer, but is also seen in inflammatory conditions, e.g. Crohn's disease. A history of chronic constipation is commonly obtained in patients with diverticular disease or anal fissures. Nausea or vomiting, these may indicate partial intestinal obstruction, particularly if associated with colicky abdominal pain. Anorexia and, particularly, weight loss, these are worrying symptoms, again possibly indicating a neoplasm but also seen in inflammatory bowel disease and intestinal TB. and can considerably predate bleeding and the development of an abdominal mass. Systemic symptoms. Fever may be vague and at best nonspecific, but reports of mouth ulcers, arthralgia, and gritty eyes are common in patients with Crohn's disease. Symptoms of pelvic disease. Ask explicitly about urethral discharge and pneumaturia, which means that there must be a fistula between bladder and bowel, and in women also inquire about vaginal symptoms such as discharge. Other relevant history. Past medical and surgical history. Inquire about the previous diagnosis or possibility of chronic liver disease with portal hypertension, which might result in rectal varices, and also about bleeding diathesis or radiotherapy to the abdomen or pelvis, either of which could lead to rectal bleeding. Take note of previous cardiovascular, cerebrovascular, or peripheral vascular disease, diabetes, hypertension or hypercholesterolemia, because they are relevant to treatment options that might be considered, e.g. assessment of surgical risk, and because the presence of vascular disease would increase the likelihood of symptoms being due to mesenteric ischemia. Angiodysplastic bleeding from the colon is said to be more common in patients with aortic valve stenosis. Drugs. Ask particularly about the use of aspirin, NSAIDs, and warfarin. Family history. The scenario states that this patient's mother had bowel cancer. Try to elicit exactly what the problem was. A family history of colorectal carcinoma or colonic polyps strengthens the argument for thorough investigation, particularly in a younger patient, although in this man's case there is no debate, he has cecal carcinoma until proved otherwise. A family history of inflammatory bowel disease might also be relevant, and remember that the rare condition of hereditary hemorrhagic telangiectasia is an autosomal dominant disorder. NB. Common causes of rectal bleeding. Hemorrhoids may have perianal symptoms, do not cause change in bowel habit. Colorectal carcinoma may have change in bowel habit and weight loss. Family history is important. Diverticular disease, history of chronic constipation and left iliac fossa pain. Plan for investigation and management. After explaining to the patient that under normal clinical circumstances you would examine him, you would plan as follows. Routine blood and radiological tests. FBC, microcytic anemia suggests chronic blood loss, a raised platelet count, inflammation or brisk bleeding. Electrolytes, renal and liver function tests. Abnormality may be an early indicator of metastatic colorectal neoplasia or suggestive of significant liver disease and therefore of rectal varices. Hypoalbuminemia may be due to protein loss from the gut and/or chronic inflammation. Coagulation studies, bleeding diathesis. Inflammatory markers may be substantially raised in diverticulitis and intestinal inflammation. Group and save or cross-match blood, if the patient is very anemic or as a prelude to surgery. CXR, look in particular for features of metastatic disease. Locating the source and cause of rectal bleeding. Frank rectal bleeding can originate anywhere in the gastrointestinal tract, including the upper tract, esophagus, stomach, or duodenum, if hemorrhage is brisk enough. Depending on the circumstances, it may therefore be necessary to examine both upper and lower ends of the bowel, but usually only the lower tract needs to be examined. Tests should be selected in the light of the clinical picture, potential benefit, local availability, and acceptability to the patient. Colonoscopy. After proctoscopy or sigmoidoscopy, this is the preferred investigation in most cases, offering direct visualization of the entire colon, Figs 5 and 6, and of the terminal ileum, with the ability to take tissue samples and, in some cases, provide therapy, including polypectomy, sclerotherapy, electrocautery, endoclip placement, and removal of lesions by endomucosal resection. The procedure is not without risk. there is a small chance of intestinal perforation, about 1 in 750, and bleeding, which is increased in cases of florid inflammation, obstructing tumors, and severe diverticulosis, or when interventions are undertaken. Barium enema. This is generally less reliable than colonoscopy in detecting colonic neoplasia and diverticular disease, cannot diagnose vascular lesions such as angiodysplasia, and it does not allow the possibility of intervention. It is now rarely used in centers where colonoscopy is readily available. Mesenteric angiography and red cell scanning. Brisk bleeding from a source that cannot be found by other tests can sometimes be identified if the patient can be investigated during the bleeding episode. Angiography has a low yield if employed when the patient is not actively bleeding, but if a source of active bleeding can be identified at angiography, then embolization of the bleeding vessel can often be performed. Investigation of an abdominal mass. Radiological imaging. A plain abdominal radiograph may show inflamed loops of bowel appearing as soft tissue shadowing containing gas. Abdominal ultrasound may reveal thickened bowel loops or an associated abscess. CT scanning is usually the preferred test. It is best able to determine the origin of a mass, and is essential in the full staging of colorectal cancer and lymphoma. Laparoscopy or laparotomy. In some patients it may not be possible to fully characterize a mass with non-invasive imaging techniques, in which case direct visualization and biopsy may be necessary. Surgery may also be needed if there are symptoms suggestive of intestinal obstruction such as nausea or vomiting. Management. Specific management will depend on the precise diagnosis. Treatment of anemia by blood transfusion and/or iron supplementation may be required.